If you zoom in on the human body during those first few weeks of fetal development, you'll see something that looks less like a person and more like a, I don't know, a rough architectural draft.
Right, yeah.
Yeah,
There's a lot of potential at that point.
exactly. Before a biological system decides exactly what it's going to be, it often starts as just the single primitive cluster of tissue. And usually as we grow, those systems
They
differentiate.
completely separate, yeah.
Right, and we just stop thinking of them as connected at all. But today, we are taking a deep dive into what happens when that hidden, shared architectural blueprint suddenly gets exposed decades later.
Which is such a fascinating physiological shift.
It totally is. We have a huge stack of clinical literature, morphometric studies, and urology journals to unpack a really specific but deeply impactful biomechanical question. Can vaginal atrophy actually alter the elasticity and the physical mechanics of the urethral meatus?
And honestly, it's a question that completely upends the traditional, compartmentalized way we tend to view women's health.
Yeah, because normally you go to a gynecologist for one issue, a urologist for another.
Exactly. But the body doesn't actually recognize those clinical boundaries. When hormone levels shift later in life, the structural engineering of the entire pelvic floor is forced into this radical, interconnected rewiring.
I do want to clarify our terminology right up front, though, because the sources we're looking at are very particular about this. The word you used earlier, vaginal atrophy, is actually something the medical community is actively trying to phase out.
They are, yeah, and for a really good reason. The update term is GSM, so that's genitourinary syndrome of menopause.
Right, because the older term implies it's just about the vagina.
Exactly. Vaginal atrophy makes it sound like the tissue breakdown happening during menopause is isolated strictly to the vagina. But as we're going to explore, the structural changes profoundly impact the urethra and the bladder, too. Calling it a syndrome acknowledges that this is, a regional collapse, not an isolated one.
Okay, so to understand how changes in the vagina could possibly alter the physical mechanics of the urethra, the tube that carries urine out of the body, we have to go back to that fetal development phase I mentioned at the start. Why are these two distinct systems so inextricably linked?
Well, it all comes down to a structure called the primitive urogenital sinus. In our very first weeks of fetal development, the genital tract and the lower urinary tract grow from this exact same clump of tissue.
They share an identical embryologic origin.
Right. And because they share that foundational blueprint, the tissues that ultimately become the vagina, the vulva, the urethra, and a very specific part of the bladder called the trigone are all uniquely constructed to run on the exact same fuel, which is estrogen.
Okay, wait, I want to visualize this bladder trigone for a second, just to make sure I'm picturing the anatomy correctly. Where exactly is that?
So if you look inside the bladder, which is basically a hollow muscular balloon, the trigone is a smooth, triangular area right at the base.
Oh,
Yeah, it's essentially the landing pad where the two tubes from the kidneys come in and the one tube, the urethra, goes out.
got it. So it's like realizing the plumbing and the drywall in a house were built using the exact same proprietary hormone-dependent material.
That is a perfect analogy, yeah.
So that triangular base, the urethra, the vagina, they are all just completely saturated with estrogen receptors because they all sprouted from that same original urogenital sinus.
Correct. They are densely packed with these receptors. During your reproductive years, estrogen is acting as the primary cellular architect for all of these structures.
Doing what exactly?
Well, it signals the blood vessels to stay wide open, ensuring robust blood flow. It prompts the cells to synthesize collagen and elastin, which gives the tissue its flexibility. It even dictates the thickness and the moisture levels of the epithelial lining. That's the surface layer of the tissue.
Wow. Okay, so let's focus on the urethra specifically. If I'm visualizing a healthy estrogen-rich urethra, I usually just picture a standard passive tube, like a little plumbing pipe that has a valve at the end, and the valve just, pinches shut to hold urine in.
A lot of people think that, but a passive pipe is entirely the wrong way to think about it.
Really? Because
Yeah.
the clinical literature describes a mechanism that is much more active and dynamic than that, right?
Oh, absolutely.
Yeah.
A healthy female urethra is a highly complex, soft, vascular structure. Yes, there are sphincter muscles, but the real marvel of continence, the ability to hold urine, happens on a micro level through something called the mucosal seal.
The mucosal seal. Okay, I struggled to grasp this concept in the reading a bit because it sounds counterintuitive. How does a mucosal lining create structural sealing power?
It helps to look at the layer just beneath the surface lining, which is called the submucosa. This layer is, well, it's practically bursting with a dense network of blood vessels. When estrogen is present, it actively promotes vasodilation, meaning it keeps those vessels wide and filled with blood. Because that submucosal layer is so heavily engorged with blood, it physically tumps up and balloons inward.
Oh, so it's compressing the empty space inside the urethra.
Exactly.
Okay, so it's like a healthy urethra isn't just a rigid pipe. It's more like a memory foam tube lined with a self-inflating water balloon.
Yes. The tissue is essentially swelling shut. Continence isn't just coming from a muscle clamping down, it's coming from the walls of the tube, inflating with blood until they press tightly against one another.
That is incredible work.
Right. Add in the natural elasticity of the collagen fibers, allowing the tissue to deform and press together without leaving any rigid gaps. Plus, the mucus acting as a natural sealant, and you have a completely watertight, dynamic closure. It's an actively pressurized gasket.
Which brings us to the central question of our deep dive. What happens when that architectural signal just stops? Menopause arrives, estrogen levels plummet, and those receptors in the urethra and the vagina are suddenly starved of the hormone they were built to respond to.
The resulting mechanical breakdown is pretty staggering, actually.
Hmm.
And it happens in a couple of distinct phases. The first major shift is physical displacement. We can call it the exposure phase.
Meaning the anatomy physically shifts location?
In a relative sense, yes. Without estrogen, the tissues surrounding the urethra, specifically the labia minora and the introitus, which is the vaginal opening, they begin to lose their volume.
They shrink.
Yeah, the tissue thins, regresses, and literally retracts inward. As those protective surrounding structures shrink away, the urethral meatus, the external opening of the tube, is left highly exposed.
It's like the tide going out on a beach and suddenly exposing a jagged rock that used to be safely submerged under the water.
That's exactly it. The clinical term for it is a telescoping effect.
Mm.
The meatus becomes incredibly prominent. And because it is suddenly jutting out without its usual protective padding, it is subjected to constant physical trauma.
From what kind of trauma?
Just everyday things.
Hmm.
The basic friction from walking, exercising, or sexual activity becomes a source of chronic irritation.
And the sources noted that this chronic friction isn't just uncomfortable, it can actually cause the tissue to morph and deform, right?
It leads to severe localized issues, yeah.
Yeah.
In some cases, the inner mucosal lining of the urethra gets so irritated that it literally rolls outward on itself, creating this donut-shaped urethral prolapse.
Ouch.
Yeah, and in other cases, the body responds to the constant trauma by growing a benign but highly sensitive and painful red lesion called a urethral caruncle.
So the urethral opening is physically exposed and getting battered, but the architecture of the tube itself is also fundamentally changing inside. The clinical study spent a lot of time on something called hyalinization. What exactly is happening at the cellular level here?
Right, so this is the stiffening phase of the breakdown. Remember earlier we said estrogen is the signal prompting cells to make fresh collagen and elastin?
Yeah.
Well, without that signal, synthesis plummets. The elastic fibers that give the tissue its stretch begin to fragment and break apart.
Yeah.
Meanwhile, the existing collagen fibers undergo hyalinization.
Which means what exactly?
It basically means they fuse together into a dense, glassy, rigid mass.
Wait, I have to admit, I always assume that as we age, tissues just sort of get universally weaker and floppier, but you're saying the urethral wall is actually getting rigid and brittle?
Exactly.
Oh,
It
yeah.
completely loses its viscoelasticity. If we go back to our pressurized gasket analogy, imagine taking a pliable, soft rubber gasket and leaving it baking in the desert sun for a year.
Right. It dries out, hardens, and cracks.
Exactly. It completely loses its ability to deform. When the tissue becomes rigid like that, it can no longer squish together to form that perfect, watertight mucosal seal we talked about.
And we aren't just guessing that it gets stiffer either. The sources included some really compelling biometric data to back this up, specifically using ultrasound shear wave elastography.
Oh, the SWE data is fascinating because it gives us a hard, quantitative measurement of this mechanical failure.
So shear wave elastography uses sound waves to measure the physical density and stiffness of a tissue, right?
Yes. Researchers looked at postmenopausal women and compared those who were continent against those suffering from stress urinary incontinence.
Which is when you leak urine during a physical exertion, like coughing or laughing.
Right. And what the sound waves revealed about the stiffness of the urethra is wild. They measure stiffness using a metric called Young's modulus, calculated in kilopascals.
Okay.
In the continent women, the stiffness of the middle section of the urethra was measured at roughly 30.7 kilopascals. In the women with stress urinary incontinence, that number rocketed up to 57.8 kilopascals.
Wait, so it basically doubles. The urethral wall has essentially calcified into a stiff pipe, just completely destroying the ability of the walls to collapse and seal.
It's massive. But the breakdown doesn't even stop with the tube itself. To fully understand why continence fails in GSM, we have to look at the structures anchoring the urethra to the pelvis.
Ah, right. This brings us to a landmark concept in urology, the hammock hypothesis, published by Delancey in 1994.
Yes, such a crucial concept. Delancey argues that continence isn't solely the responsibility of the urethra. It is heavily dependent on the backboard that the urethra rests against.
So picture a firm suburethral hammock sitting underneath the urethra.
Exactly. This hammock is constructed from the anterior wall of the vagina, the pelvic floor muscles, and a crucial layer called the endopelvic fascia.
Let's define the endopelvic fascia for a second, because we hear the word fascia a lot in fitness spaces, usually regarding stretching. But what is its role here in the pelvis?
Fascia is essentially the biological saran wrap, or internal mesh, that encases and supports your organs. It holds them in their proper anatomical positions. It's super rich in connective tissue.
Okay, so the endopelvic fascia weaves together with the vaginal wall to create this firm, supportive layer.
Right. And that matters, because when you cough, sneeze, or jump, the pressure inside your abdomen spikes dramatically.
And that spike in intra-abdominal pressure pushes down forcefully on the bladder and the urethra.
Exactly. But if the urethra is resting on a firm, supportive hammock, that downward pressure is actually a good thing.
Wait, really? Good how?
Because the pressure squashes the urethra against the firm backboard of the hammock, pinching the tube shut and preventing leaks.
Oh, this reminds me of stepping on a garden hose that happens to be lying on a concrete driveway. Your foot provides the downward pressure, the hard concrete provides the resistance, and the hose flattens out, stopping the flow of water instantly.
It is the exact same physical principle, yes. The driveway is the suburethral hammock.
But here's where the mechanics get a bit mind-bending for me. We just established that because of the shared embryologic blueprint, the lack of estrogen causes the urethra to become stiff and rigid. So if the urethra is getting stiff from lack of estrogen, does the supporting hammock get stiff too?
You think so, but this is where we uncover a massive, cruel irony in pelvic biomechanics.
Uh-oh.
Yeah, the different tissues react to the loss of estrogen in opposite yet equally destructive ways. While the urethral wall undergoes hyalinization and becomes stiff, the connective tissue forming the hammock experiences severe matrix degradation.
Matrix degradation meaning the cellular scaffolding just falls apart.
Yes, the extracellular matrix is the web of proteins and fibers that gives connective tissue its structural integrity and tension. Without estrogen, the scaffolding breaks down.
So it actually gets looser.
Exactly. The pelvic floor muscles lose their tone, the fascia thins out, and the anterior vaginal wall loses its firmness. The elastography studies confirm that the hammock actually becomes lax. Its elasticity increases, and its stiffness drops.
I am trying to picture the sheer mechanical disaster of this. We have a urethra that has turned into a stiff, inflexible pipe, and it is resting on a hammock that has turned into a loose, sagging net.
Yes. Going back to your garden hose analogy, the system has completely inverted. You no longer have a soft rubber hose resting on a concrete driveway. You have a rigid PVC pipe resting on a loose trampoline.
Wow. So when that spike of abdominal pressure hits, the PVC pipe cannot compress because it's too stiff?
Right, and it doesn't have a firm backboard to pinch against anyway. It simply sinks deeper into the trampoline. The pressure transmission fails entirely, and urine escapes.
That paints such a clear, devastating picture of how intertwined these two systems are. You truly cannot separate the vaginal atrophy from the urinary incontinence. GSM is just a complete architectural collapse of both the pipe and the support beams.
And this mechanical collapse triggers a cascade of very real daily repercussions for you. Stress urinary incontinence is just one piece of the puzzle.
Oh, what else does it cause?
The sources also highlight urge incontinence, which is that sudden, overwhelming, uncontrollable need to rush to the bathroom.
I would assume urge incontinence is tied back to that bladder trigone we talked about earlier.
It is, yeah. The trigone is densely populated with sensory nerves. When those estrogen receptors in the trigone are starved, the sensory nerves can become highly irritable and hypersensitive.
So the bladder begins signaling that it is desperately full, even when it isn't.
Precisely. The clinical literature also documents severe dyspareunia, or painful sex, stemming directly from the loss of natural lubrication and the thinning, friable nature of the vaginal walls.
We also really need to talk about the recurrent urinary tract infections, which the sources frame not just as a nuisance, but as a direct result of a collapsed biochemical defense system. How does the loss of estrogen suddenly make someone prone to UTIs?
It's a fascinating chain reaction, really. During your reproductive years, estrogen ensures that the cells lining your vagina are packed with glycogen, which is essentially stored sugar.
Okay, sugar.
Right, and you have a population of beneficial bacteria naturally living in the vagina called lactobacilli. They feed on that glycogen, and as a byproduct of digesting it, they produce lactic acid.
Which keeps the internal environment of the vagina highly acidic.
Yeah, exactly. A healthy, estrogen-rich vagina maintains a pH between 3.5 and 5.0. That acidity is a hostile environment for harmful infection-causing bacteria like E. coli. It acts as an invisible biochemical shield.
So it's preventing bad bacteria from colonizing the vagina and traveling up into that newly exposed urethral meatus we talked about.
Exactly.
So let me guess the cascade here. Estrogen drops, so the glycogen disappears. The lactobacilli starve to death. The lactic acid production stops, and the pH just skyrockets.
You nailed it. The pH shifts from acidic to alkaline. The shield drops. Pathogenic bacteria can now easily thrive, multiply, and ascend into the urinary tract, causing recurrent painful UTIs.
And the critical takeaway from the clinical guidelines is that unlike hot flashes or mood swings, which, often naturally subside as the body eventually adjusts to the new hormonal baseline GSM, is progressive.
This is so important for people to understand, meaning if you don't actively intervene, the architectural breakdown just continues to deteriorate. The tissue won't magically rebuild its own collagen or restore its own glycogen without help.
It's a structural issue. Without treatment, the physical mechanics only worsen.
Precisely.
Which brings us to the interventions. Everything we've discussed so far sounds structurally catastrophic. I want to spend significant time on how we actually reverse this engineering failure, because the literature emphasizes that there are highly effective targeted therapies available.
They really are.
Let's start with the baseline options.
So for mild cases, the first-line recommendations are over-the-counter non-hormonal moisturizers and lubricants. These are designed to alleviate the immediate symptoms of dryness and reduce the friction on that exposed urethral meatus.
But they don't fix the underlying architecture, right?
Right. It is vital to understand that they are purely symptom management. They do not penetrate the cells to reverse the hyalinization or rebuild the hammock.
To rebuild the foundation, you have to bring back the cellular architect. The sources point to local low-dose vaginal estrogen as the gold standard for moderate to severe GSM. I want to understand the mechanics of this, though. How does applying a topical cream or a localized insert actually reverse a physical structural breakdown?
Well, it targets the root cause directly at the receptor level. Local estrogen is applied directly into the vagina via creams, slow-release rings, or tiny tablets.
And because the dose is incredibly low and localized, it stays primarily within the tissues of the pelvic floor.
Exactly, avoiding significant systemic absorption into your bloodstream. When those estrogen receptors in the vagina, urethra, and trigone finally receive the signal again, the machinery turns back on.
So it actually prompts the submucosa to rebuild that vascular network.
It really does. It restores the robust blood flow, pulling the tissue out of that rigid, hyalinized state. The cells begin synthesizing collagen again, returning flexibility and softness to the urethral wall. The memory foam-like mucosal seal plumps back up.
Wow, and I imagine it fixes the UTI issue, too.
It prompts the epithelial cells to store glycogen again, which resurrects the lactobacilli population, drops the pH back to an acidic level, and restores your biological shield against UTIs.
It's quite literally reversing the aging process of the specific tissue.
Hmm.
But local estrogen isn't the only foundational treatment mentioned. The literature also deeply analyzed vaginal DHEA. What is the mechanical difference between using local estrogen and using DHEA?
So DHEA operates on a principle called intracrinology. DHEA itself is an inactive precursor hormone. When it is inserted vaginally, the local cells absorb it and actually convert it into both active estrogens and active androgens, like testosterone, strictly inside the cell.
That seems like an incredibly complex metabolic trick. Why go through the extra step of using a precursor instead of just giving the tissue estrogen directly?
The primary advantage is precision. Because the conversion happens intracellularly, essentially zero active hormone leaks into the general blood circulation.
Oh, that makes sense.
Right. It provides a highly effective alternative for patients who might have contraindications or strong personal aversions to using direct estrogen therapy. while still achieving the exact same tissue rebuilding results.
There is also an oral medication listed in the sources called osbemifene. But wait, if GSM requires localized treatment, how does taking a pill not affect the rest of the body?
Great question. Osbemifene is part of a class of drugs called serum-selective estrogen receptor modulators. Its mechanism is fascinating because it is highly tissue-specific.
How so?
Well, when it binds to estrogen receptors in the vaginal tissue, it acts as an agonist. It mimics the effects of estrogen, thickening the mucosa and reducing the structural stiffness.
But the selective part means it doesn't act that way everywhere.
Exactly. In breast tissue, for instance, it acts as an antagonist, meaning it actually blocks the estrogen receptors rather than stimulating them. It's a systemic oral pill that manages to deliver localized, targeted effects to the pelvic floor.
Those are all biochemical solutions targeting the tissues of the urethra and vaginal wall. But what about the hammock? If the endopelvic fascia has degraded and the muscles have lost their tone, can the biochemical treatments fix that, or do we need mechanical interventions?
For the muscular components of the hammock, pelvic floor physical therapy is heavily recommended, often utilized in tandem with the local hormone therapies.
I'm trying to picture how physical therapy solves the PVC pipe on a trampoline issue. Is it just doing Kegels to tighten the trampoline back up?
It is far more nuanced than simple strengthening. In many cases of GSM, the chronic pain, friction, and urinary burning cause the pelvic floor muscles to enter a state of provoked hypertonia.
So they are constantly spasming and clenching in a defensive guarding mechanism.
Often, yes. So the muscles are actually exhausted and tight, rather than just weak and floppy. A specialized physical therapist works to manually release those hypertonic spasms, retrain the neuromuscular coordination, and ultimately reestablish a functional, responsive hammock that can properly absorb that intra-abdominal pressure.
Finally, the sources spent some time discussing emerging device-driven therapies, specifically photobiomodulation using fractional CO2 lasers or radiofrequency energy inside the vagina. Firing lasers into the pelvic floor sounds like science fiction to me. What is the physiological goal there?
The underlying principle is controlled microtrauma. The laser, or radiofrequency device, applies thermal energy to the vaginal lining, creating microscopic injuries. The body responds to these micro-injuries by triggering a massive wound-healing cascade.
Oh, it's essentially the exact same mechanism as microneedling on your face, where you intentionally damage the skin to force it to produce fresh, youthful collagen and elastin.
That is the exact physiological parallel. The goal is to rapidly stimulate the synthesis of new connective tissue and prompt the growth of new blood vessels, restoring the elasticity of the hammock and the urethral support without relying on hormone receptors at all.
That sounds incredibly promising for people who cannot or will not use hormonal therapies. Is it considered a standard replacement for local estrogen yet?
Not quite yet. The major medical and urological societies are maintaining a stance of cautious optimism. While early observational studies show significant improvements in elasticity and symptom relief, there is a strong consensus that we need larger, long-term, sham-controlled data, basically placebo-controlled trials.
To prove its long-term safety and efficacy before it can officially supplant local estrogen as a first-line standard of care.
Exactly.
Well, we have covered a massive amount of biomechanical ground today. Let's trace the arc of what we've discovered. We started by asking if vaginal atrophy alters the mechanics of the urethra. The answer is a profound yes, driven by a shared embryonic blueprint that forever ties these systems to a single hormone.
Right.
When estrogen vanishes, the dynamic, well-vascularized mucosal seal dries out. The flexible tissue of the urethra hyalinizes into a stiff, brittle pipe, and its physical location telescopes outward into exposure. Simultaneously, the supporting extracellular matrix of the hammock degrades, leaving a rigid tube bouncing against a loose net. The biological shield drops, inviting infections, and the sensory nerves misfire.
It's a massive chain reaction.
It really is. But most importantly, we learned that this cascade is not an irreversible consequence of time. Whether through localized hormones, precursor conversions, or targeted microtrauma, the cellular machinery can be turned back on.
It is a remarkable testament to how interconnected our physical architecture really is, which honestly leaves me with a final, slightly provocative thought to mull over.
Okay, let's hear it.
If our early embryologic development permanently links our urinary and reproductive health so deeply that a hormonal shift decades later causes them to collapse in tandem, it forces you to wonder, what other completely separate mechanical systems in our bodies are secretly sharing a hidden blueprint, just waiting for a specific chemical shift to suddenly reveal how connected they really are.
Wow, that is something that will definitely change how you view the unseen engineering inside your own body. Because as the clinical data proves, the body is never just an isolated set of broken parts. It is a dynamic, interconnected landscape that demands a much deeper look. Thanks for joining us on this deep dive. Keep questioning the incredible mechanics of you.